Good afternoon, everybody. It's Patrick Flood and Mary Moulton here in Montpelier with some other folks. And before we really get started, let's go around to the different sites and check in. So, could we go to Bennington, please?
This is the technician in Bennington. We have no participants at this time.
Okay, thank you. How about Brattleboro?
This is the technician in Brattleboro. We currently have no participants.
Off to a good start. How about Johnson?
This is the technician in Johnson, and we have no participants at this time.
And Lindenville?
The tech in Lindenville, there's no one here.
Going to go home pretty soon. How about Middlebury?
Ruth Grant. Okay.
Hi, Ruth.
Hi, Ruth. Hi.
You look, so far you won the door prize.
Yeah, I'm the only one here.
I bet it'll change. How about Newport?
This is a technician in Newport. Currently, there's no one here.
What about Randolph Center?
This is the Randolph technician, and we have no participants at the moment.
And Rutland?
Hi, this is Sarah Neller, here to listen and maybe comment.
Okay. St. Albans?
This is the technician in St. Albans. We have no participants.
And White River Junction?
This is the technician in White River Junction, and we have no participants at this time.
And last but not least, Williston.
Hey, we're here.
All right. Hi.
This is
Bob Bick.
Mental Health.
Sally Fox.
Good to see you all.
Sally Fox, I'm here to listen.
All right, well, we...
Hi, this is
others
in Brattleboro. There's others here.
Somebody is in Brattleboro? Let's go back to Brattleboro
Sadie.
for a minute.
Sadie.
Sadie.
Well, I'm pretty confident people will show up as we go along here, but I always make a practice of checking in with the sites.
There's more people here.
Patrick, sorry, this is Nick. Do you want to hear who else is here in Williston?
I actually don't care really about a roster or anything, Nick. We'll get to people as we go around. I hope they're not taking offense at that.
Oh, yeah, a little bit.
They are, but that's okay.
There we are.
We'll have to
okay.
give them the door prize, too.
All right, door prizes all around. Well, thanks, everybody, for coming out. As I said, I'm sure we'll be joined by some others as we get going here. The point of today was really to follow up on the conference that we had on September 13th. There was an awful lot of information shared that day with an awful lot of people, and we originally that day had thought we might have a second day, basically, where we got together and talked about now what? Now that we have all this going on, all these initiatives, and everybody's fully informed, what should we do? But then, for a variety of reasons, that wasn't going to work out, so we decided to have a session like this and just invite anybody to participate and to give us their comments on both where they think we are, what's working, what's not working, but also what have we missed? What should we be doing that we're not doing yet? That's really the most important part of this is where do we go from here? Now, we're not prepared today to reiterate or repeat all the information about where initiatives are, et cetera. It was really more an opportunity for you to talk to us about what you think we need to do. So it's going to be really interactive, and what you need to do if you haven't participated in interactive television before, the way it works is if you want to speak, you say something and the camera will come find you. Now, the way it works best is if you say, for example, this is Bob Bick in Williston, and just wait a few seconds and the camera will come and find you for the most part. If you don't, just keep talking because that's how the camera will come find you. But I think the best thing you can do is say your name, say where you are, and then the camera will come find you. When you see yourself on a monitor, you're ready to go. It's pretty simple, actually. Let's try. Who can we try it with without? Who did we see? Jeff Rothenberg. Do you want to say something?
Sure, Patrick. I'd be happy to say something. I could keep talking and hope the camera finds me.
There it is.
There
I go.
Okay, so that's sort of the way it works. And there's no way to keep people from talking over each other sometimes. Some people may want to say something at the same time. We just have to sort that out. Whoever's on the screen has the floor. Okay, so with that, we're really just going to dive in and ask people, what their questions or suggestions are for us, and just leave it at that. Do you want to say anything, Mary?
No, not in particular at this point in time. I think I'm more interested to hear what folks have to say for feedback, and happy to fill in for questions, too, if you have questions.
So is everybody clear? Does anybody have any questions about what I just said? Okay, well then, if not, again, just repeat for some people who came in late. We're here to hear from you. We're here to hear your questions or your suggestions. But where do we go from here? What's missing? That kind of thing. It's really an open forum.
How are you deciding who speaks and when?
Okay, for those of you who came in just a tiny bit late, the way this works is you just speak into the microphone and the camera will come and find you. And what I've said to folks is you should say your name and where you are, and then actually keep talking a little bit so the camera can come find you. But if you say where you are, Laura Ziegler in Montpelier, that gives the technicians a chance to come and find you. As I say, you just speak into the mic and the camera will come and find you, which, by the way, is a little bit of a warning. Be careful what you say to your neighbor because the camera may come find you, and you may not be ready for that. So, yes.
Yeah.
Yes, it is. Yes, it is. So it's completely open. We're not going to go around site by site or anything like that. We're just going to let people speak up.
This is Connie Stabler in Williston. This is Connie Stabler in Williston.
Good job, Connie.
I just wanted to be clear on what the focus of what you're looking for here. I was not able to attend the conference that you had, and my understanding is you were talking about perhaps where things are right now, and what's going well and what's not, or were you more focused on the future and what you're working on for the future?
Well, both. Actually, it's a completely open forum. You can bring up anything that's on your mind. Primarily, we were thinking about, so there's all this work going on in Vermont right now in hospitals and designated agencies and peer organizations, all these initiatives going forward, and we wanted to know either how's it going from your perspective, or what have we missed, or what's not working well, but also what should we be doing next? What should be on the to-do list? But you can bring up anything you want.
Well, I was just curious as to how you are feeling about what you have in place right now to deal with the situation we're in before all the other facilities open. For instance, how is it going in the hospitals? Do you feel like we have less of a backup in the ERs? Is that going any better? Are people in the community being seen by community mental health agencies? Are they getting more services now to help keep them out of the hospital? I haven't heard an update about that in a while.
All right, well, let me give you an update from my perspective on the hospital picture, and then I'm going to ask Mary to give you an update on the picture in designated agency land.
Thank you.
The situation in the hospitals and access to acute inpatient beds is still a crisis. Every single day, we have somebody waiting somewhere for acute care, and now in most cases, the acute care, the care management team working with the hospitals and designated agencies are able to get people into an appropriate hospital bed in a day or two. There have been cases where that's taken 3, 4, or even 5 days. So it all depends on the needs of the patients. But the situation has not gotten any better. Let me say that. If anything, it's gotten worse since 6 or 7 or 8 months ago. And I can't explain that, but that's my assessment. Now, having said that, we're getting ready to open the 8-bed temporary hospital in Morrisville in about 3 weeks. And we're all looking forward to that because that will take pressure off the system, especially in the northern part of the state. So that's the situation. It really hasn't gotten any better. Now, we know that we are diverting people from hospitals every day through crisis beds and other care. We also know that there have been people going to the emergency room and sometimes staying there for a day and then going home, sometimes more than a day, but then ending up going home and not really needing to be in a hospital. So, this whole situation we're in is giving us information or snapshots in time that we didn't have in the old days. So we're still all trying to figure out what that really means. Does anybody want to add to that? Any of the DMH staff? Or anybody want to contradict that and say that's not a good description of what's happening?
I could tell. This is Ruth Brand in Middlebury.
There you are.
Keep talking.
Hi, Ruth. Hi. I don't know if this is the appropriate format or not, but I had an experience with my family member on October 5th that was concerning to me, where he didn't need to be hospitalized, but he was being held in central Vermont, and they were going to send him to the retreat. And it's a somewhat of a story. Do you want me to tell about that? They were trying to admit him, and there were no beds, and it turned out nothing had changed, and he didn't need to be admitted. But I didn't get called. His psychiatrist didn't call, and his case manager didn't get called. So they were just operating in a vacuum, making this decision without the history they needed. And I almost contacted you, Patrick, or you, Mary, because I wrote a lot of letters to other people trying to prevent it from happening again. But, this caused me to be concerned, at least in this one case, the person did not need to be in the hospital. And the problem was the people from the designated mental health agency weren't contacting the right people to get more information.
Right. Well, and Ruth, I think each situation like that is going to be different as to whether the designated agency knows those people because they're within their system or they're served by a different system.
Yeah. He was known in this system, which is why it's just stupefied me why I wasn't called right away.
Yeah.
But anyway.
And so most certainly, I couldn't agree with you more. A record should be checked for contact information, and family members, particularly guardians, should be phoned for more information. So, that's something that certainly in any review that we hear about, we would go back to the designated agency and talk to them about that.
Okay. Well, I can
and
give
join
you more information.
Join you with that conversation.
I wrote to the designated agency, but I haven't heard back from them. So maybe you could help facilitate that. But we don't need to do this in front of the whole crowd.
I'd be happy to.
Yeah.
Be happy to.
Yeah.
We all do want that feedback.
Yeah.
So, and Mary, do you want to talk
Talk a little bit more about the communities, and certainly the communities are out there so people can talk about what they're doing. But, the communities were very excited about having an infusion of enhanced programming. So where that is from the department's oversight of how that's going is we first looked at, in my review, because I was involved in as a liaison with the community mental health centers with the designated agencies, looking at mobile crisis and building that out, and also with hiring more case managers for outpatient services. So the designated agencies have been very involved in that process. They've certainly been challenged in hiring qualified people, and I think in some areas they continue to be challenged, in some areas more than others. Mobile crisis has made some real strides in establishing communication protocols with state police and is now working on a training. That will be an interdisciplinary training for police and mobile crisis teams to actually have a training day together. And so we have a committee that's been working on that training, and we have what will be an executive training day coming up in November, which will invite leadership from state police, community police, law enforcement, sheriffs, other entities of law enforcement, as well as mental health crisis teams to give feedback on the proposal for the training day that we would like to do. So that's been happening, and the agencies are at different levels of readiness in going out and doing mobile crisis. Some are actively doing it, and they're really working on it right now. I think there are 2 that have voiced to me that they are struggling still with hiring, and that is the major difficulty in getting out and on a consistent basis as a matter of practice in their communities. So that's mobile crisis. The case management piece, I'm just about to make another round of all the agencies to discuss how that's going. Those that I've met with thus far have said they are very excited about the prevention work they feel that's happening, the ability to see people on the outpatient side of the agency and actually offer some services that they weren't able to do before, to help them with housing, to help them with employment, to help them with benefits, things that they were not able to do before. And the agency I just met with actually was Washington County Mental Health to review that process, and they said, we feel like we're going to have some information coming out soon that will be able to actually equate to some outcomes. But it's just beginning. So that's what's happening, and that's very exciting. But it is also, because we don't have a system of an entire system of open yet with hospital beds, it's a lot that the community is carrying right now, and I think that we really recognize that.
Can I have a follow-up question? This is Connie. Again, can I just ask another question to follow up on that? So the different agencies then are doing different things with the money. For instance, I know a lot of them, their case management levels that the managers were carrying was incredibly high, and they've used it to hire more people so that they aren't necessarily giving more people case managers, but their case managers are then able to have less people to work with and perhaps do more for them. But I imagine in other places it might mean that more people might be getting case management services. So it's open to them what they do with that case management. It's just to improve that system. Is that correct?
It's true that when they presented their proposals, each agency had different gaps that they wanted to fill. And those that added on case management for the purpose of serving additional people through this extra resource, as I was saying, can only mention Washington County right now because I haven't got the update from everyone, but they indicated they think that they had served through a much more aggressive case management outpatient model up to 50 people thus far since it started. So I'm interested to hear what others are doing.
Well, that's great. That's great. And then I had one follow-up question on the hospital report that Patrick gave.
Sure.
When you open the Morrisville facility, will Fletcher Allen still, I know they have some sort of contract with the department to provide the state hospital level care for a certain number of beds, I guess. Will that still remain in place, or will they, because there's this new 8-bed facility, stop doing that or reduce the number of beds there? Because I think it's still going to be needed, it sounds like.
Yeah, it is going to be needed. The point of putting all this work into an interim hospital or temporary hospital was to meet the unmet demand out there, to try to meet it. So it's certainly our expectation that Fletcher Allen will continue to serve what we refer to now as level 1 patients. It will take some pressure off of them and their ER, and it will be, I believe that they will feel the difference, but we're certainly hoping that they will continue to serve those patients as well. Now that is our agreement until the new 25-bed hospital is built. And at that point, Fletcher Allen will return to basically not serving level 1 patients, or maybe occasionally, but not routinely. But until that's built, our expectation is that they will continue to do this. And we do have a contract with them, or almost done with them, which lays that all out. Okay. Anybody else? You might need to get a little closer to the mic, Ed.
Thanks. I guess a clarifying question. Even before the flood, etc., Fletcher Allen did serve a lot of folks on EE status, and while they were getting the AITs going, is it anticipated that they anticipating doing less of that than they did? Because I would certainly describe some of those patients as level 1 patients, not long term, but.
Well, I believe that Fletcher Allen will continue to serve involuntary patients even after the new hospital opens. That was the case before the flood. The hospital served a lot of involuntary people, yes. But a certain level of care or level of need went to the Vermont State Hospital. Now that's distributed, but the hospitals will continue to serve other involuntary patients. Anybody else? Yes, Mark.
Hi, this is Lynn Klom in Rutland.
Hi, Lynn.
Hi.
You're on.
Am I up? Okay.
Yes, you are.
This question is in a little bit different direction, but in the work that I'm doing with systems, I'm finding that there's still some communication problems, especially between primary care providers and designated agencies, that might, if there was better communication, might result in us doing some more prevention work. Is there any work being done on a universal release form, or at least a release form for the designated agencies that they might all be able to agree on?
And the benefit of a universal release form would be that what?
Well, I've got because I've got situations where, for example, a primary care provider is in one county and a mental health provider is in another county. And so it's creating problems with communication and with overall case planning for people.
I wonder if maybe, Julie, has anything happened with the council on that kind of work? I mean, people work really hard on their release forms at the designated agencies, and they become sewn because of the work to their particular release form. For example, there may be a release form that has an array of choices, a menu of what you would, who you would want to, and under what circumstances release information. So I don't know if anybody's taken that kind of maybe overall release form that has everything on it and tried to apply it universally across the agencies. And that's why I'm asking if Julie Tesler's here from the council knows of any work that might be done on behalf of the agencies right now through the council.
I hadn't heard that this was a recent issue. I know that years back we developed a standard business associates agreement, but I understand that there's variations that have developed since then. If it's something that would be helpful for us to revisit, we'd be glad to do that, because we wouldn't want that to hinder health integration. We're very committed to it.
Okay, great. Thank you.
It's a business.
Lynn Klom is one of the AHS field service directors, and I wonder, Lynn, if there's benefit to inviting Julie Tesler or somebody from the council to one of your meetings to talk about what you're encountering.
Okay, I can talk to folks about making that happen. Thank you.
Okay. Anybody else?
This is Betty Keller in St. Johnsbury. While we're talking about release forms, Betty Keller in St. Johnsbury. Am I not close enough?
No, you're on.
We can see you, Betty.
Okay. Okay. I'm just seeing you still. So I'm in St. Johnsbury, and I trained as a family physician, but have been home with the kids for the last while. And the last few years, I've been particularly at home because of challenges with an adult child with a mental illness. And while we're talking about release of information forms, there's the issue of the billing issues. If you're an adult child, the child's under 26 or is still on COBRA or whatever, and then there are the getting access to care issues. And we have a challenge right now that you have somebody who has some organization issues. Forms can get mailed to him, and they may or may not get signed and sent back to where they need to go. He doesn't live at home. He actually moved to California for a treatment program there and is trying to establish there, but he's still on our insurance. And so we have the Blue Cross Blue Shield forms that were signed previously. There are the Magellan signs that were signed previously. He went on to COBRA. He has to re-sign both of those and re-sign Blue Cross to address things that happened before he went on to COBRA. So basically he needs to have 3 different forms signed, and we've only gotten 2 of them back to them appropriately. And I am actually visiting him in California. We'll print it out, have him sign it, and mail it myself. But this should not be so hard, especially for him to have to give him permission again to deal with old bills from March, just because in September his insurance changed. And he already gave permission for us to deal with his bills for him.
I think that was an advertisement for single-payer systems.
That's why I'm working for it, volunteering for it.
Yeah, I don't know how much we can do here about that, but it's a dreadful story of all those interplaying parts.
And that's just the billing. Now I'm also trying to figure about the getting the care. I'm visiting in California, and is a family visit going to be covered? And yes, if it's billed under mine, and when he changed, does he have another deductible to go through starting in September? You have to start all over with that. And nobody can give me a clear answer. They say, well, after you get the bill, then you can look at it and you can argue with us over it. But as far as getting the care, it's a real challenge, and it again is those having to have the multiple release forms to have a family participate in their care and advocate for them and try to make the appointments for them and that sort of thing.
Well, it must be a nightmare. I don't know what we can do unless somebody here has some ideas. Right now,
I'm just thinking that if he were in Vermont, it might still be an issue also. And is there any way, legislatively, can we advocate for there not being quite so much paperwork? It seems like an insurance company shouldn't require that you have 3 different forms for the same insurance company with the same client and the same family.
Well, I would say that those discussions are going on in Vermont, but I've been involved in enough of them to know that really we're at the beginning of that change process. We have a lot of work to do. There's a mandate actually in statute that tells us to integrate mental health care with other forms of care and with health care reform. And that work has started, and I do believe people are taking it seriously. But, boy, it gets complicated really fast when you start talking about the kind of issues that you're bringing up. So it is being worked on in Vermont. I think people are aware of it. I just think it's going to take us a while before we iron that all out.
Well, and speaking of the parity, there is no special board to go to if you have a cardiovascular problem, like Magellan for behavioral health. So I guess it was written in as an exception when they were writing the law that they could have a separate company for that. I mean, why do we have a Magellan involved when it doesn't speak to parity at all?
Well, we have somebody I consider an expert on that question in the room if she's willing to answer.
I certainly,
should say your name, Ann,
yes, Representative Ann Donahue, under the hat I've just been asked to respond under. We have a long-standing problem with that. You are correct. When the parity law was written as a compromise to overcome insurance company concerns, parity was encompassed or allowed to encompass companies farming out managed care for mental health, even if the rest of the product was not managed care or they were managing it themselves. And that does seem to be, certainly from my perspective, it's an obstacle to true parity. It is something that is now on the radar of the Green Mountain Care Board and has been on the radar of the legislature, but has not yet been barred as an insurance company practice to subcontract.
Thank you. Does that answer your question? Give you a sort of a status report?
It tells me that we're working on it. Thank you.
Yeah, it's a lot of work to be done. Mark, say your name and where you are.
Mark Kaufman, Montpelier. If we could get just a brief status overview of the integration of services between the mental health reform efforts, Green Mountain Care, and the unification or simplification of the AHS application process, especially as it relates to unified and electronic communications. Sorry.
I was with you until you said the unified AHS application process. Talk about having a lot of work to do. I actually can't really answer that very well for you, Mark. I know that, when DCF did their started their modernization project, it ran aground and a couple of, and I don't know what the status of that is right now, but I don't think they've solved all their problems. So you're referring to people trying to actually access care and how difficult it is to apply and
across multiple programs. And then as we move forward into Green Mountain Care, or even through the Affordable Care Act in a year and a half, it ties in with other things that have been said. How many applications do I have to fill out?
Again, I know that the goal of a single-payer system is you fill out one, but even having said that, within HS, so if you apply for health care, does that mean you can apply for food stamps and everything at the same time? And that's been sort of a holy grail for years and years, and we did have the unified application for Medicaid and food stamps and fuel assistance, and it ran 27 or 28 pages. Yeah. Now in an electronic world, can that and should that be easier? Yeah, I think the answer is yes, but are we there yet? No, we are not. I haven't actually tried to go into myself and apply for anything and see the challenges that people run into, but I hear there are still lots and lots of challenges trying to use the electronic system. So I don't know what else to tell you except it has not fulfilled its goals yet. And with healthcare coming, we have to have that, I think, in place. And I, once again, know there are people working on it and vendors that have been contracted with, but I can't give you an update on where it actually stands in implementation.
Thank you.
Anybody else out there have a question or a concern?
Can you hear me? This is Jacqueline in the Williston office. Can you hear me?
Okay, keep talking. Hello? There you are. Okay, Mark.
Hi. Sorry.
It's quite all right. Go ahead.
So I work at the Vermont Refugee Resettlement Program, so I'm here kind of wearing two interrelated hats because I work with refugees at our office, but I coordinate the interpreter services so people access our services from around the state. And so we watch the modernization process greatly affect our clients at AHS. And mostly I'm here to kind of bring forward the problem. I don't know if that makes it better or worse. I'm not here to ask for a solution, but more like as we're working forward, as we're looking forward, to mention that there are people who have linguistic challenges. There are people who, I'm just imagining the situations that you've just laid out from around the state, adding in a layer of they don't speak English, they can't read or write, with all those forms to sign, with all the coordination, and then with the assessment, the actual assessment having to be linguistically accessed and culturally adapted. So just to kind of bring that up, because as we've seen decentralization happen in other related areas, it can definitely impact services to both the refugees that are coming in, but also to immigrants around the state. And we get requests from, from Spanish across the state, from all. And as we get lesser diffuse languages from those more isolated areas, then there are even fewer experts, as we would call them, if they've worked with clients with these challenges before. And so who do they go to and how do they coordinate? When there was a central place, at least there was kind of more centralized information. And so we're concerned about making sure that that information and that resources are accessible statewide.
Well, again, the Department of Mental Health right now has limited input into how that whole application process goes. But here's a question I'd like to ask you as long as you're on the screen. One of the one of the concerns on our radar, and has been for a while, is the delivery of mental health services to refugees, which presents very tough and unique challenges. And I'm wondering if you can give us your impressions or some kind of a status report on that.
Well, I'm kind of glad you asked. Again, as you said in your last question, I'm not sure that I can really answer it, but I can tell you snippets of what I've seen. Basically, I sit in my office and I hear stories from all different sides, from all different people. So what I'm gathering, and what I gathered today from our staff members when I asked them what to bring forward, was difficulty, especially with the assessment process. When someone comes from a different culture and a different language, they need an interpreter, but then their culture is different and their level of reading and writing and understanding is completely different. And so we are seeing some real difficulty with people who have developmental challenges, to physical difficulties, to mental health issues that may or may not interact, and people who can take the time and gather the resources to be able to sort those out, to really know where to send those people to get further care. So we've definitely seen that, you know, within our pockets locally, but also and especially, like I said, with those lesser diffused languages further out where people are isolated, and there are fewer resources and fewer people with that experience.
Okay, I'm just going to stay with this subject for a minute. Is Bob Bick still there in Williston?
Yes, I am, Patrick.
Hello, Bob. Do you want to comment on the whole question of refugees and mental health?
Well, you know, I think it's a significant challenge. It's certainly a challenge here in Chittenden County with the volume of individuals that we're seeing, not only at the adult service area level, but also in children's services and developmental services. Internally, as an organization, we're going through a process to identify additional ways in which to provide translation services. We've hooked up with UVM and Fletcher Allen in terms of trying to leverage some of the resources that they've built into their system. We do have a contract with a phone service translation company, but as you can imagine, for doing the kind of clinical work that we do, it's not really advantageous. Part of the challenge, obviously, with some of the populations having other local individuals do translating, given the intimacy of the communities, presents a little bit of a challenge for us. So we are continuing to work on it. We know it's an issue, and we certainly welcome any suggestions that anybody's prepared to put on the table that will help move it along more quickly.
Okay, thanks. You're breaking up a little bit, but I think people got the gist of what you were trying to say. Yeah, it is a problem, and you have small communities of, you know, refugees from here for there. It's really hard to find, you know, services for that population. The folks in Chittenden County have a real challenge, and I know that Trish is here, and I know that we had conversation with not the refugee coordinator at AHS, but also somebody from UVM, right? And
So there was a meeting held at
say your name and where you are so we can come find you.
Trish Singer, Montpelier. There was a meeting held, I think a couple of months ago is now, that was hosted by Howard Center, that included some state-level staff that are working on refugee issues, as well as UVM staff, and also representatives from the refugee community themselves, to identify what are some of the most pressing needs and some of the barriers to addressing those. It was interesting. One of the leaders of an African refugee group actually said his number one item on his wish list was a community center. That in terms of the mental health of their community, having a community center where they could meet together as a community and actually also address their spiritual needs as a community. For him, it was interesting because, you know, we had all thought he would say, well, I need treatment for this or treatment for that. And he was actually talking about, you know, a community resource. So the needs of the community are much broader than, you know, getting a specific treatment intervention for a specific mental health challenge. And so it is a really broad conversation, and they are engaging in that. We have another meeting, I think it's the end of this month to come back and take a look at what we can do in terms of bringing the resources that we have available to help sort of address some of these problems.
Okay, thanks. Other questions or concerns?
This is Mark Ames, and I'm on Montpelier. And I have two things I wanted to address, but I think that the first thing to do is compliment you, because the work you've been doing with law enforcement came to my mind immediately listening to, and it's both of you, came to mind immediately listening to John Dillon's story on tasers, on VPR, because the people that are the victims of being tased have mental illness and substance abuse problems, and they're the people that Mary's been working with getting a solution for. And it was, I thought it was interesting to hear a news story and know the background story and know that you're actually developing a solution that wasn't identified during the press release. And I thought that was well worthy of a compliment, because it doesn't usually come around that way. And I'd be interested to have an update on how that's going.
Well, the idea of the training, as you know, law enforcement is trained to move forward. And what we're working to do is to develop different tactics for law enforcement that encourages them in some situations to slow down, and also, though, to have the kind of support they need through folks on mental health crisis teams who, if it's safe, could go out with them to assist in a situation. And this has been happening in some parts of the state, for a while, but it definitely is not a practice pattern throughout the entire state. So, and we have never trained together on this. So that's the different piece, is that we will actually offer a training day where we'll review case scenarios that will challenge the different approaches to how we respond to an emergency, and to learn how to network those pieces together, and hopefully to come up with the best and safest solution that we can, given what we're faced with in the community. So that's that is the goal of training together, and absolutely lowering the incidence of use of taser, or other means of having to secure someone physically. If we could do that with communication, then that should be our first, tactic, and then we go beyond that. So we're working on that. That's a big challenge for us, and I have to say that from the standpoint of public safety right now, I think as we roll this training out, we'll hear more from the Public Safety Commissioner on this himself. But I have to say, in our conversations with him right now and with his leadership team, it's been very positive. And there's been a tremendous amount of support toward a training that would help move us all in the direction where we have a better response to our folks in the community who are in mental health crisis. So.
This is Betty in St. Johnsbury again. I'm wondering, where does Vermont stand with in relation to other states on the same issue? I know that San Francisco has been making a big issue over this, and they were getting a team from, I don't know, Kentucky or Tennessee that had integrated mental health crisis workers better into it. Are we looking at outside resources like that? Do we have a sense of, are we kind of in the middle of the pack or at the leading edge, or are there lots of resources we can draw from because other people are further along?
Well, that's a crisis intervention team model. That's a CIT team is out of Tennessee. It's the Memphis model that you're referring to, I think. I'm familiar with it. Actually, yeah, the person who...
That sounds right.
Yeah, Cindy Taylor Patch, who is the director of the Pittsford Training Academy, actually has been to that training. So we're familiar with that training. I've seen that training. I've looked at the curriculum. We don't have funding for CIT training, in spite of some of our legislators' attempts at getting that. I'm looking at Representative Donahue right now. But what we do have is willingness and some know-how, because some of us have actually done that kind of outreach for a long time and work with police. And I've done that myself for 20 years. So, using the
people that we know on the ground who have done that work together. We're actually developing a similar curriculum, and we'll look for, in each police agency, we would invite all police to attend this training, and we'll do it regionally, but we're looking for what CIT calls champions, and our law enforcement community is not fond of that terminology, but they have bought into the term mental health liaisons. And we'll have hopefully one per shift through the week who will be mentor-like or leaders within the police agency. And that's a group that we will seek in every police agency to train for mental health, for response to people in mental health crisis. And they will be networking with an outreach crisis team to assist on scene. So that's the ultimate model that we're working toward.
Thank you.
I think it should be just mentioned as well that while we're focused primarily on folks with mental health crisis, it's going to be interesting to see how it plays out with law enforcement with other persons in some kind of a crisis, especially folks with developmental disability, for example, because law enforcement are never going to be trained to be experts in any of these areas. But we hope that there will be, what's the word I want? An expansion, that the work we're doing with law enforcement will expand to be a benefit to many others, basically. So I can tell you, the police are very, very happy to have this happening. They've been asking for it for years. And so we are just getting started, but we're making a lot of progress pretty quickly.
Thank you.
You're welcome. Anybody else? Next.
This is Connie Stabler again. If I can just ask another question. I wanted to get an update on, or have you tell me what's going on with involuntary treatment hearings. I understand that they're going on when someone is being held involuntarily, and then there needs to be a court hearing to hold them further, and whether they're to get them treated. Most of those hearings, my understanding, used to be done when someone was in the state hospital.
Can't hear you right now, Connie.
Okay. Trying to get closer. Can you hear me now? No?
I can. I'm not sure closeness is the issue, but go ahead.
Okay. Speaking loud, I'm trying to find out what is happening right now with court hearings for people who are in the process of determining if they can be involuntarily treated. Did you get that?
It did.
Question?
I'm not sure exactly what.
Because I think most of those hearings used to be done at the state hospital, and so I understand they've been done probably in other areas, like in Burlington for people at Fletcher Allen, maybe in the retreat area for those, and wondered how that process was working and how long the waiting process was taking. Has been taking, whether that has been able to be expedited at all, because it was taking 60 days or so for someone to finally get treatment after 2 hearings. And then if that's what's going on now, would that go away and we'd go back when the new facility, 25-bed facility, is built? Would we go back to sending everyone there that needed to be held longer than a few weeks? Would that go back to sending everyone there so that the hearings would mostly?
Well, let me start with the last question first, if I can, because when the new hospital is built, it will be part of basically a 45-bed system that includes 25 beds in Berlin, 14 beds at the retreat, 6 beds in Rutland. They will all be part of that system. They will all serve involuntary. They will all serve level 1 patients, and they will all serve forensic clients. The idea is to spread the care out. So not everybody would go to the 25-bed facility. The rest of your question, I'm probably not the best person to try to answer it, but my understanding is, right after the flood, there was a lot of confusion about getting court hearings where and when and who, because people had to travel all over. Most of that has sorted itself out. Now, there were some I think it was, I'm going to be confused now, was it Rutland or was it Brattleboro, where they actually tried to set up a courtroom in the hospital? Both. And in one case, I think they stopped doing it because it, you know more than me, so why don't you talk?
Well, Brattleboro and Rutland were able to hold court in the hospital. Brattleboro on campus, actually. It was on campus. And so the judge discontinued that, probably late winter. And in Rutland, I believe they still do hold some hearings within the hospital. And if you're referring to what hospitals can do applications for involuntary medication, yes. Rutland and Brattleboro are the two hospitals right now that do, and Fletcher Allen, sorry, the three hospitals, Fletcher, Rutland, and Brattleboro do that right now. Central Vermont Medical Center does not do that, and nor does Wyndham. So that, and we had a backlog prior to the flood, and I'm going to defer to Representative Donahue, because you indicated you know something perhaps about timelines right now, or you were nodding. So let you answer what part of it you can.
Thank you, Ann Donahue again. Yes, the dashboard, the draft dashboard that the department is developing had information on that, and when it was presented to the Mental Health Oversight Committee last week, that was actually one of the questions that was brought up, and the department was asked to respond to or look at what was the comparison, or what is the comparison in the length of time, if there is a difference from previously. The other issue was a question of, now that it's dispersed, are they occurring more frequently or less frequently? How does it compare with previous practice? And without having those numbers in front of us at the time, I can tell you that it appears that it is occurring, applications for involuntary medication are occurring perhaps 3 times more frequently than they did when it was only at VSH. I'm not commenting on the spot whether that's a good or a bad thing. Different perspectives would see it differently. But I think that does need to be looked at and evaluated. Does this mean that there are more appropriate uses, or does it mean that it's being overused, perhaps inappropriately? Because if the numbers are very different, that tells us that we should at least be looking at it.
Agreed.
I would think that that might be due to the fact that the hospitals don't want to keep people, hold people for 60 days before they can get someone treated, whereas that was tolerated more at the state hospital.
If I can comment on that again,
I would love to.
I think that in previous reports and comments from the state hospital doctors, I think many of the providers there felt that it was very important to not move too quickly, because people, when they were worked with, did in fact engage voluntarily, and when they engaged voluntarily, they were much more likely to continue treatment rather than just discontinue when they left the hospital. So I think that's one of the things that would need to be looked into, because if it's happening more frequently because of pressure to have briefer stays, that isn't necessarily a positive.
I agree. I was just wondering if that might be it. Would I be able to get that information that was presented to the Oversight Committee somehow?
Sure.
Well, right.
It's on the website, isn't it?
But we don't have the comparative piece.
Right. The problem was that the information that was on the dashboard we saw, and that apparently is on the website, is only lists how many applications have been occurring each month. And if I'm recalling correctly, I think it was 3 or 4 per month. If you multiply that by 12 months, if that's in the range of about 40 per year, I think that's somewhere in the range of more than double or triple prior years historically at VSH.
Without the
I
numbers
would
in
be-
front of us, yeah.
I was
Connie,
gonna-
I guess
I
what
would
I'm
be-
saying is, go ahead.
I would be interested in knowing how long the process is taking, and compared to how long it took at the state hospital. If that information is available, how might I get that?
We're putting together some of those comparative figures. We have a new quality assurance person that we've hired as our director. So she is working on that, and I believe had a conversation this week around some of the things that would be helpful to put on there. This is one of them. So we're going to start offering some comparative data, and once we get that done, which should be fairly shortly, we can get that to you. Yeah,
Thank you very much.
and it goes
Thank you.
and it'll go on the website as well.
Yeah, that was one of the specific pieces of information that the Mental Health Oversight Committee members asked for.
I see Frank
Thank you.
Reed taking good notes back there. So, right, Frank?
Yes,
so,
I've got it.
We'll make sure we don't lose that.
Okay, there's been language on the books.
Where are you?
Sorry, Laura Ziegler Montpelier. There's been language on the books since 1998 about the department being required to work to minimize the use of coercion and toward a system where there was no use of involuntary medication. There's now language on the books about making alternative treatments options available to people wishing to avoid or reduce their reliance on medication. There's also a record of really high-end use of psychiatric drugs in Vermont generally compared to the rest of the country. If the figures from DOC were any indication, since according to DOC, what they were getting was not originating in corrections, it was coming out of the community. And there's also language in Act 79 about honoring people's treatment choices whenever possible, to the extent possible. I'm interested in how this is going to be or is being reflected in actual practice. And I don't mean an oasis of alternative for a handful of people, but the everyday practice of prescribing, of leaning on people, of conditioning services, on taking pharmaceuticals, the implementation of Act 114 on things like, and I say this from records that I've read, and they were not within the last couple of years, but I doubt things have changed tremendously, on seeking forced drugging orders on people who already have tardive dyskinesia from the drugs, on putting in petitions for a range of a drug that goes way beyond what the FDA has indicated as the maximum recommended dose. I would like to know what DMH is doing to roll some of this back, to adapt the paradigm to some of the newer and more discouraging information about the drugs and their efficacy and adverse effects, as well as adhering to the principles, and I realize principles are only principles and tend to get honored in the breach often, but directions like minimizing coercion have somehow either been mostly ignored or perverted into maximizing some kinds of coercion for a theoretical minimizing of other kinds of coercion. And I'd like to know what is being done. And that includes, and I think this is very important, when people are trying to make a choice to go off psychiatric drugs after being on them for years, I don't think it's enough to just say, okay, you can do this. People need gradual step down, and more than that, it's often a very rough ride. It's not always successful, and I think people need what may amount to secure settings for this, the same way that they can access such settings if they were trying, let's say, to go off of an addiction to opiates. So I realize it's a rather broad question, but it's a rather broad topic, and now I'll shut up and let you speak.
Well, I think we're starting to do a number of things, but to get at the really the heart of your question, which is how is the state system of mental health trying to minimize or eliminate
Or
coercion.
enable people to do it, not
Well,
just...
the last
yeah.
part of your question is something that has been brought up, and I think there is a need to find a way or a place, or both, for persons who wish to taper off their medications to do that in a safe way. Because we do see cases where people just stop, and it has very bad effect on them usually. So there is a need there. Nothing is planned right now to do that. It was talked about a little bit when we came up with a proposal around the Soteria House that it could be used for that purpose, but I think we've steered away from that now. Good. And that there really needs to be a separate process or a separate place, or more than one.
Practice,
Yeah,
not just
practice,
a process.
exactly.
Yeah.
So that's under discussion, but it's really early, and there's no proposal to come up with that just yet, but maybe that's why we're here.
Right, and I don't expect DMH to suddenly address everything that it's avoided dealing with for many years, because if you have to do everything at once, you won't do any of it well. But when it comes to things like informed consent, like having actual choices, like having real support, like narrowly tailoring what the state does in situations where it is going to override people's decisions so that it's not just riding roughshod and going to extreme ends. And it would be nice to see this at least started with the understanding that you have an outrageous demand on your time right now in multiple directions. And so this is not like, why haven't you done it yet? It's more,
well, I think it's a
start?
great point. Yeah, I think it's a great point. There's certainly a lot of grassroots or consumer interest in this, and how we're going to turn it from an idea into a policy and a practice, I'm just not clear about that yet, but I do know there are lots of other people involved. I had a long conversation with Dr. Steingard not too long ago from the Howard Center, and she is actively looking at some of these issues and how we most appropriately use medications and how we most appropriately taper people off and stuff. And I know Dr. Batra has also talked with me about medication use and in polypharmacy and how do we manage some of that better. So I think there's a starting of a very complex conversation, but I don't think we're going to turn back and ignore it. The only sort of analogy I can use right now is, we also, I think the department didn't make much progress, let me put it that way, on issues like minimizing coercion in transportation. And yet, Mary took that on when she came to the department back in March, and I think we've made a lot of progress on that. So it's one of those other areas which may have languished for a number of years. But what you're asking about is a much bigger topic.
Yeah, and it includes just, number one, the paradigm and trying to nudge it a little bit in another direction, and also education, including of prescribers, including private sector prescribers that you don't have a whole lot of control over or even contact with. So it may be that there is some affirmative education that needs to be going on. I mean, we can sit down and listen to Robert Whitaker. Not everybody is as receptive as some of us to that message, but it's really not about choosing who you want to hear so much as there is some hard data which has been pretty studiously ignored, and there's also a lot of marketing in the guise of education which has really been sucked down. And I think it requires affirmative remedial efforts to address that, especially because while it goes on in all of medicine, it's really gone on in psychiatry, and Vermont seems to have been particularly receptive to that particular propaganda as reflected in its practice. And I think because DMH has some responsibility to set the tone for the whole state, that it requires more than just trying to ride herd on what you do directly. I mean, am I correct in that? Because when I look up your mandate and statute, it's a lot broader than just being responsible for what you do. You're responsible in some ways for the status of mental health care in the state. And the mental health care in the state is very chemically dependent and very coercive, despite the mandate to minimize coercion and work toward that, and despite what is filtering in by way of a different perspective on what constitutes best practice. Mm-hmm. So I guess the question is, what resources do you have to bring to bear on this? Are you willing to sponsor, underwrite, bring in so that you have educational forums? Could you work with UVM, or is UVM part of the problem? Can you work with the DAs, or are the DAs part of the problem? Sorry, Julie, but I do need to say this. Is there a way to try and create a different knowledge base?
I think education is absolutely key, and the decentralized system that we have right now, I believe we're going to learn a lot from just by looking at these numbers. So if indeed we see, and we might expect some change, that we have 2 or 3 times more applications for involuntary medication, that if we see that, we absolutely have a responsibility as a department to say how do we gather to do something about that, and what should be done. Dr. Batra, we were referencing in the beginning the conference that we had, and so he did have a workshop that day on
Poly?
Yeah, yes. on polypharm and psychotropic meds, and so I think that kind of education needs to get out there even among his colleagues. And he recently went down to Brattleboro with a team from DMH and actually did a really nice clinical consult with them, which he wants to continue to do. So I think that's one step, one tiny little step, but I think that's a step in the right direction. And how we could get that further out to primary care providers and, designated agencies, and have more of that education out there, just like primary care providers actually need a hotline for how they're prescribing pain meds. We need to have that kind of professional consultation, I think, within the field. So he's doing that. I know he wants to do more education around that. We have open dialogue, actually, that will be also coming. It's a different part of that component, but it's an important part about how we're talking to people, and when we're actually working with them. And Nick has actually, I see Nick on the screen, he's actually set that up, and to actually have that come up. When is that, Nick? In
December 7th?
December
7th.
So, yep, December 7th.
I got to say, and this comes from working on, as part of the Act 80 work group on law enforcement training, in the same way that law enforcement seems very uncomfortable with having anyone second guess their actual use of force as opposed to de-escalation, I think clinicians are very uncomfortable with having anyone second guess what they feel is best practice. But I do feel that it is important to have some of the more expert critics, and I'm not really referring to Bob Whitaker here so much as people who have clinical backgrounds themselves and have been kind of stuck in the role of iconoclasts for a long time, instead, even though what they're saying should be pretty mainstream, to have them take a look at what's considered best practice standards here and maybe revisit and revise some of what's considered best practice in light of some of this uncomfortable information that's been coming to light. Because it's all very well and good to provide a space for Robert Whitaker and to hear these very challenging criticisms, but I think they have to translate into changed practice. And they also need to be conveyed to the users of the system and not just the clinicians. You're talking about undoing decades of propaganda and marketing, and that's not an easy task.
This is Betty Keller in St. Johnsbury.
Yep, go ahead.
Did somebody else speak at the same time? Okay. Speaking to that, I can say that from primary care, I was trained in family practice at UVM and then residency in Utah. My general impression would be that primary care physicians in general have not been impressed for many years over the efficacy of medications for psychiatric use. They just haven't seen a lot of other options. And I'm really looking forward to how we'll see changes in the Blueprint for Health change practice, because if a primary care doctor only has a 15-minute block and they're hearing that the patient is depressed, they've been told, well, this drug works better than anything else that you have in your own handbag there, but you have a mental health worker in the office or easily accessible that you can refer the patient to for further evaluation. I think that this will make a huge improvement in the clinical practice. for those practices that have a mental health worker accessible like that. So I'm really hopeful for that. I do have that was my actually number one question that I hadn't asked yet, and that is, I've heard about this dashboard for quite a long while now, but as a parent or for an actual patient or as a primary care provider, just wondering what is out there when you have one of your families needing mental health services, especially if they're not on the blueprint and don't have that provider right there to help. Will there be a website that's really easy to find so that the parent at home having a crisis in front of them will be able to Google something and find out if they never had any experience in mental health services and something bizarre is happening, can they punch in some obvious lay words and find out, oh, what should I do? Like, they don't even know yet to call 211, So I'm wondering, what are we going to do to make mental health services accessible to everybody, like even the family trying to figure out what to do? But also the primary care provider, if they don't know about these different house this, Silver Lake that, what's for what level, like can there be a diagram that says these are what these things are for?
Yes, there can be, and there should be, and I think all they'd have to do is type in mental health in Vermont, and the department's website will come up. The real question is, does the department's website begin to answer those questions? That's the real question. The quality
and is it
of
organized in right? Is it organized in a way that's easily accessible?
That's the question. So it makes sense to us. Does it make sense to somebody who's a user? And what have we done to evaluate that over the years? So I would love it actually if some users or consumers or people like yourself would just go on there and say, does this help me at all? Or what am I missing? Because that'll tell us really what we need to do to make it more useful for everybody.
Mm-hmm.
You want to give that a try and send me an email and let me know what you think?
I think that I should talk with Lori Zucker, and we should sit down in front of a computer together sometime. Lori?
Yeah, well, that'd be great. I mean, that's another whole area that I think our website has an awful lot of information on it. But whether it's, configured the right way or whether it's what people want, whether you can get there quickly.
Right, and it can be really hard, too. You have people at different levels, like what a college student seeing a bizarre roommate can access versus what a parent who has never been on Facebook or this or that, or providers, that don't use that sort of thing. If they're not used to using websites and it takes too long for them to fit in their business day, then they won't.
Right. Good point.
I'll take a look at that.
Okay.
Julie had a comment.
Oh, okay. I have follow-up, I guess, for two now.
Name and where you are.
Julie Tessler at Montpelier. For Laura's, and actually I want to then refer this to Nick Nichols, the new evidence-based practice co-op, which will be funded, is going to be done by Southern New Hampshire University. I wonder if that might be a resource that we could use to provide training for psychiatrists, family practitioners around medication use. And maybe, I don't know how that would work with what Dr. Batra's doing. If his focus is on polypharm, that's a little different than Laura's recommendation that we look at the use of pharmacy overall. And I think that makes sense to do that. Now I'm forgetting what the second point that was just brought up was.
Well, I could fill the space.
I know, the website. I think people who want to access mental health services, we do have designated agencies, but we also have private mental health counselors and psychologists. And I hear them saying, we need a central place that people can find us to. And as much as I promote what designated agencies do, we're not the total solution. There are people for whom going to a counselor is a better solution, and people need to be able to access those services, and then we'll use designated agencies where we need to use them.
It really needs to be integrated well.
We've got a lot of work to do on our website. I can.
Well, that's certainly something we can take back, and that doesn't sound too complicated, so we can get to work on that piece quickly. I would like Nick to comment, if he would, on Julie's point, because my understanding of the educational collaborative that we're trying to develop, Nick, is that it very much could be used for this kind of cross-system education and training. That's really what we're trying to do now. It's a limited amount of money, so what you do when will be up for discussion. But certainly, there's no reason we can't use it to work with physicians and prescribers too. Do you want to respond to that, Nick?
Yes, I would love to. So a couple different points. In terms of the Evidence-Based Practices Cooperative, it's a new entity that we're creating that will hopefully include members of all the various stakeholder groups in the state. And one of its primary foci will be practice improvement. And I've been talking with Dr. Batra about using the cooperative potentially to follow up the high level of interest at looking at the use of polypharmacy and what are the practice guidelines or what are best practices for psychiatrists to be following around that. And so I think that's definitely, that potentially could be a really great vehicle to have a sustained initiative focusing on that. And in fact, the group that helped create the concept of the Evidence-Based Practices Cooperative actually did a full-day retreat with our community psychiatrists, medical directors, looking at the use of polypharmacy, and the psychiatrists on their own actually started to develop some specific guidelines to reduce the use of polypharmacy for the treatment of psychosis, and so that is part of what we're planning to focus on. I also wanted to say in terms of the blueprint, for folks who don't know, one of the key elements of the blueprint sites is they're going to have a strong resource base of self-management groups and workshops. And through all of the blueprint sites, we are planning on making RAP available for people with mental health issues. And so hopefully when a primary care physician is meeting with someone for their 15 minutes and the person is showing signs of depression, as opposed to feeling like they only have medication as a tool, these workshops will be available to help people as opposed to just getting a prescription for Zoloft or something like that. Lastly, I also wanted to mention in terms of family resources, NAMI actually produces a very good family resource guide, which is designed for family members who have no knowledge of mental illness or the mental health system, and it's a really great resource. And I know when NAMI goes around and does their family education classes around the state, that's included. And what we may want to talk about is how to make sure the primary care physicians are really aware of what NAMI does and the support and resources that they can make available to these family members, because they're really set up to, I think, help with some of the issues that that was brought up earlier. And we could probably also look at, if it's not already, putting the Family Resource Guide, a link to it on our website.
Sure. Okay. Other comments, questions?
I can't believe Bob Bick has not had anything.
I don't get any. I'm going to use my backlog. I just want to give other people.
I'd like to bring some up. This is Mark Ames. I'm in Montpelier. And one of the things I came here today to ask you to consider is how are we going to move. Last year we started discussing how we would make the recovery centers, which are seeing people that have co-occurring disorders, more part of the system, peer services system that you've been working to support. And I don't presume to tell you what to do, but I want to remind you that here we have a group of peer organizations, 11 of them around the state, that 75%, better than 75% of the people coming in self-identify as having co-occurring disorders. So we're doing a lot of the work that supports mental health in Vermont. But we don't have any direct resources from your department, and we particularly lack training. And one of the things that I've been listening to the conversations about RAP groups being touted about as a part of the blueprint model. Initially, when we started the recovery centers, a number of people from the recovery centers had been RAP trained. but we can't afford to get RAP training. And if you were to be able to make that part of some of the system available, there's a whole group of peer organizations that are willing to provide that service and have in the past and do now, but don't have the sufficiently trained people there to do it. And the problem, of course, for recovery centers, as you well know, is that they're hopelessly underfunded right now, as being able to have enough staff on hand to respond to people's needs, even with large volunteer workforces. And I'd love to invite you to make some extemporaneous comments about this and see where you'd like to see this going.
Well, I have a lot of respect for the recovery centers. I've been to a number of them, as I think you know. I've looked at your data, and it is impressive. One of my questions back is, what has been the extent of the work between the recovery centers and the designated agencies, for example, some of whom are also, substance abuse providers? How's that local contact working? Is that extemporaneous enough for you?
That's extemporaneous enough. Now, I can say that it happens in varying degrees depending on which designated agency it is, and I'm not going to name names but there are some agencies that are doing really active collaboration with their recovery centers. The Challenges for Change grant that HCRS got that's supporting recovery coaching in the Springfield Recovery Center is a really good model and an example of active collaboration between a designated agency and a recovery center. There's a lot of really good work happening in that center. And there are other places where there's very little commitment on the part of a designated agency to help support and develop the recovery center's work. So it's all over the map. But the issue is that Springfield is one of the centers that the board had the presence of mind to buy their building, so they have a larger percentage of their annual grant from the state that they can use for delivering services versus paying rent and utilities. There are a number of places that fit that category. That place in St. Johnsbury, the hospital gives the Kingdom Recovery Center their facility for $1 a year. So there's much more staff support devoted to doing this work. There's good collaboration up there, and the Blueprint team and the recovery center are all an integrated whole there, which is very promising. It's happening on varying degrees in different places, but the challenge is that the centers right now, as we're moving toward healthcare reform, centers don't have a staff of experienced peer workers that can deliver the models like RAP. If you run a program on volunteer-driven services, you can't maintain formal peer support, recovery support services, and that's the hurdle that we're looking to overcome.
Well, I'd also like to put Julie Tesler on the spot for a minute, representing the council, and just say, from your perspective, how's it working with the recovery centers? Because what I'm looking for here is, what is the best path to success? And we don't want to make something up all over again here, but we are charged with integrating. So I want to get a sense for where are we in terms of integrating so we can support the right process to get us fully integrated.
I don't have the answer. I wish I did. I would have spoken up all by myself if I did. But I certainly think it's an opportunity. So, if we've got a model where it's working, how can we extend that to other regions? So we can certainly look into that and figure out a way to share that information. So glad to look into it. I just don't know the answer. I can't speak for all the different recovery centers and agencies. I don't know the relationships.
It might be good just to have that discussion and formalize. Let's pull together yet another meeting, but with the right people to have this conversation about what is working. We have models that work. I think the idea of integrating with the Blueprint is critical. I think that certainly we should be integrating recovery centers with the DAs. So what does that look like from region to region? It can look a little different, but the basics I think we should be doing. So what is it going to take to do that? And I hear you loud and clear that you don't have enough funding. And I'm not suggesting we take it away from the DAs to fund you. I'm not suggesting that at all. but I think we need to
So
scope.
Bob has a contract out on me if you do.
I just think we need to scope out where we are and where do we want to go and what are some of the steps. And I'm sitting here looking at Senator Ayer from Addison County, who's right in front of me, but I know that one of her real strong interests is how do we integrate all of this. She's the chair of the Health and Welfare Committee in the Senate, and I wanted to bring it up when she asked me. So, but I know that that's a very strong interest. So let's just make a commitment to get together and scope it out in the next couple of months.
That'd be great.
Mark
Kaufman, Montpelier. I'd be very interested in talking with Mark and with the DAs, which we're planning to do anyway, under the new peer-to-peer Vermont Peer Network grant, because we'll be specifically coordinating some RAP training, and I think that kind of let's just move forward. Let's start talking.
That's a good point. We should really make sure you're part of that discussion.
Mark, could I ask a question? I know you have your RAP listed as for some of your centers as being available or offered. Is that coming in from peers that are doing RAP through the DA system? Because RAP training, that will be given in a particular region. I mean, there's a class and it's given, and anyone can avail themselves of that. But I'm wondering if you've specifically tapped into the DA where a RAP series is being given and asked them to bring it to Turning Point. Has that actually connection been made within to give the RAP class to Turning Point? These are, as you say, these are volunteers, and it's exactly what Mark's getting at, but I'm just wondering if it's happened yet anywhere.
The people that have been part of our network that are RAP trained have gone to Mary Ellen Copeland's trainings, not through the designated agencies. Now, there are RAP groups being run by, for instance, psychiatric survivors folk at the centers and NAMI folks. I mean, so there's interchange because we're all collaborating with each other, but the centers themselves don't have the capacity to do this as a part of what they do, and it makes sense, but they are doing other recovery support services. This is just one that hasn't come to the forefront yet. But it's, for instance, making recovery easier, which is indicated for dual diagnosis folks, is something that, and I could say that that's something that, for instance, in the Burlington area, the drug court, which is a Howard program, refers everybody to that group at the recovery center as part of the standard practice to integrate people into recovery. And so there's some real strong collaborations already in place. It's just a matter of there isn't enough infrastructure to do it on the recovery center side.
Okay.
This is somewhat related. Looking at these things as tools for people when they lack capacity, and it's not RAP, but there was a change in the law a few years ago to make voluntary guardianship more inclusive, to remove some discriminatory language. And there's also been law for a long time providing for advanced directives, and that has been sorted out as far as its applicability to people with psychiatric disabilities. I was wondering if DMH can help in providing resources, like training resources, especially online resources in this area. And when it comes to guardians, because there is such a shortage of private guardians and a lot of, let's say, excessive demands potentially on the office of the public guardian, to try and help develop resources so that when people are in need of that kind of less intrusive substituted decision making, that it's accessible and that people utilize it. I know advanced directives are notoriously underutilized, even though the mechanism is there. Would it be possible for DMH to affirmatively offer training like this, put together informational material? I think there would be a problem with RAP because it's copyrighted, I suspect, but the other stuff is just the law, and it should be available to the public. And I know DRVD does some, but does DMH do anything on this?
So you're talking about information to consumers or citizens?
To train it. Well, not just to people who use the system, but like the question we just got, it's not just RAP. There are other mechanisms so that when people are planning, if they plan, or when people around them are trying to let them know what their options are, so that, I mean, personally, I think there are situations where commitment might be avoided if someone had a voluntary guardian. If you get, I mean, and I know there's someone that a friend of mine and I see regularly who's a former VSH patient who has major TBI and psych, and I told the designated agency about voluntary guardian because this person would have been adamantly opposed to guardianship, and they ended up getting a voluntary guardian. But it wasn't like they knew about this. I just think that these are the tools available, and yet they tend to remain underutilized, and that the agency could play some part in teaching people what's available. I mean, I don't know if what I'm saying makes any sense. I'm not a provider. I don't know what comes to the table, but I suspect this could help, as well as create a demand which is hard to fill for voluntary guardians. But in general, you want to do the least coercive things first and the most collaborative things first, and they tend to be more sustainable in the long run. So
yeah, as you're talking, I'm just thinking I have some experience with guardianship.
From Dale, right?
It is a big problem, especially for persons with mental health conditions, about what the rules are, what would work, what doesn't work. You know, in the senior world of elders, it's a little clearer. In the world of developmental disabilities, I think it's a little clearer. This field, I'm basically acknowledging what you're saying is a problem. I think that to really tackle it effectively would require some resources we don't currently have. When you have an Office of Public Guardian in Dale, you can do this kind of work. It's part of their charge. We don't have that in mental health, so we'd have to think about how we would do it. But my experience tells me it would be a fair amount of work. You'd have a full-time person who really did nothing but outreach and creation, materials and.
It's also almost non-existent in corrections, which is a real problem when people lose capacity and they're in corrections. And while I did kind of bring this up in the SFI work group, it's really not something that's their focus. But it's troubling when a state agency appears to never have heard of something that's pretty basic in law when they do have people who lack capacity, because it's really not okay to be making healthcare decisions for someone else or failing to make any healthcare decisions and letting people languish until there's an emergent situation, if then. When the guidance is pretty clear and you are responsible for someone and they're in your custody and would probably qualify as a vulnerable adult, but I think that is the situation. And I think also, I remember years ago checking, and VSH was pretty bad at applying for guardianship of people who had major health issues that would just be let go. And that's a terrible reflection on the value of human life. They would apply for forced drugging orders. They would say the person lacks capacity, but there was nothing happening when there were other medical issues. And it just.
Well, it's a good thing to talk about more because I don't think it really has been talked about in the public way in a long time. Whether and I'm not trying to create a new silo, but just for purposes of illustration, whether the Department of Mental Health should have its own Office of Public Guardian. I have no idea what the response to that would be. Phone's going off, so I'm going to put it in my pocket. So I think it's a big question, Laura, and I don't have a quick response for you, but I do think it's something that needs to be talked about more.
I also know for CRT clients at the designated agencies, there was a real press to be asking each person if they had an advance directive. And Frank, is that currently part of what is required through the CRT process at all, through paperwork?
It is required that they be made aware of advance directives, and if they want to make advance directives, that they give them materials and help them to do that if they want to.
What I thought. So I think it would be good to look at how often that is happening, and I don't believe that we track that. But I think it would be good for us to ask that question because it's very important to have that
And
piece.
people who are marginalized often don't know anyone who could act as a rep. The law changed. Now you can have an instructional directive that doesn't require an agent, but it's still, with a voluntary guardian, there's a clearer path to a person It's just that I know from being on a task force on guardianship, which was legislatively mandated a number of years ago and never issued a report, but I was one of the people on it, that there is a huge problem with getting people to serve, which is where I'm thinking, there's a resource development aspect to this. It's just that it's not going to magically create resources if you focus on it. Yeah. But if you don't focus on it, there's definitely going to be a continued deficiency.
Ann? I just want to comment on that's the first I'd heard about agencies informing people about advance directives. I have encountered often a confusion that people have between having a crisis plan and having an advance directive. Mm-hmm. And I think crisis plans may be being encouraged a lot without really understanding the difference and perhaps not actively encouraging advance directives. And specific to that, the RAP plan helps someone with a crisis plan and really pretty strongly implies in the material that this doesn't use the word advance directive, but implies that this is the mechanism and the tool for advance decisions. Really it sort of implies that it's parallel, which of course it's not at all. So I think that's worth looking into a little when you're looking into that question.
And just as an additional point of information, I was trying to avoid that question because I have some rather pungent comments on that, which I'd rather not make here. But there is federal rule, at least for hospitals, that you must do this community education, not just tell people when they walk in your door. And that's in the conditions of participation. You can look it up. I think that tends to be more honored in the breach, too. That's it.
Okay. The reason I remember it is because I really remember it being at one point in time, and it might be several years ago, really impressed upon the agency that they needed to make this initiative with every CRT client.
Well, at one time there
Maybe
was.
Need to reinvigorate
well,
that.
It was worse. At one time there was some kind of manual out of DMH that told the community agencies they didn't have to follow advance directives if someone was on involuntary status, never mind committed, which is absolutely not the law, but it was what people were being told. So it's necessary to take great care in what constitutes education, just like education or promotion of crisis plans should not remotely imply that they are on par with an advance directive or constitute an advance directive. Otherwise, what you're doing is misinforming people and helping them bypass the legal instrument that they could access if they knew what it was and how you do it.
Mm-hmm. Boy, lots to do. Anybody else? Questions, concerns, comments?
Hear me yet? Hi. I just wanted to bring up again my perspective because I've been listening to all this and I feel, first of all, very privileged because I feel like there's a wealth of knowledge that's been discussed and in my role I don't always get to be part of this conversation. I'm only vaguely aware of the RAP program and how it works. I've been attending some of the Blueprint meetings, but I can't help but look at it all through this lens that I have, which makes me concerned in some ways, but also very hopeful, because I feel that there are so many people working on so many ends to make this work very well. But my concern is that in the past, we haven't seen a lot of effort to make this accessible to people who have linguistic challenges. So I just wanted to put it out there again because it seems like there are a lot of ways to make this accessible. And just to be mindful of that from this point forward, that all these, for example, some of the notes I've been taking about involuntary treatment and getting things signed, having vulnerable adults that you have voluntary guardianship, you have all these things. When you think about layering the linguistic dilemmas, the linguistic barriers on top of that, trying to educate the whole family on how to deal with all of this. Not saying that we need to recreate the wheel, and I totally get it now, why we get providers calling me, wanting to throw up their hands, because on top of all these very complex issues, now they've got to deal with the whole oh my gosh, there's this whole other issue of the linguistic accessibility. But the truth is that some of it we can make pretty accessible with simple steps. Just making, for example, links on a website with some various languages, just pointing them in various directions. For example, if the community came forward and said, we'd like a community center, maybe finding some community leaders who we can identify and we can make sure to get the stream of information out in certain directions and in certain languages. I just wanted to point that out because I think that there are some really good things that are about to happen. And it would be great if we could be mindful about ways to get it out to the various populations that are also out there not understanding English.
Yeah, one of the big challenges has been and continues to be translating key documents into various languages. That has been a huge stumbling block for as long as I can remember. So when you start talking about things like advanced directives, where there's a standard form in law, not that you have to use it all the time, but those kinds of documents, getting them translated into 6 or 7 common languages in Chittenden County is, boy, we're just not there. And yet, that's what really needs to be done at some point.
Well, and maybe perhaps sometimes you don't need the entire documents or all of the documents translated right away, but getting key parts of that, key pieces of information out so that then leaders from those communities, people who are involved in those communities and or have the expertise and work in the field, who speak those languages, can then help to get that information and put the pieces together. So really kind of, rather than trying to get everything done completely in every language, figuring out and really thinking about what actually we need to accomplish in order to get the job done and not overworking ourselves and overspending to get, everything translated.
Okay. Could I ask you again what organization you work for?
Yeah, I work for the Vermont Refugee Resettlement Program.
Okay.
Which is part of USCRI.
Yep. I am familiar
Thank
with
you.
them. I just didn't pick it up in the beginning. Other thoughts, comments? If not, we're wrapping up. Thank you all very much. I will say that this is not exactly what I expected, but I think it was extremely informative. It is a long list of things that need to be tackled here. And it's going to take time to get through all this, but I think we should probably host events like this more frequently just so people can come in and tell us what's going on, hear what's going on, and continue to make suggestions. I just think I'm just going to ask people in the audience if they find it helpful to be able to use the VIT method here, because otherwise when we have meetings, we get pretty good participation, but we don't get people from all over the state.
Do you remember when I brought up the old systems improvement meetings as something that needed to be restored? And I know you have the Transformation Council. I think that's a little different because it's got an agenda that's set for it. I think what you just did today with the statewide access added on is closest to that, where it's an open agenda. You ask people for their input. You talk about it with them. You don't appoint people to represent folks. You just put yourself open and you meet with them. And I think this should definitely be continued, as much as I personally have a problem with VIT. It's just a hard thing to follow. But it's worth it for the geographic equity.
Yeah. Okay.
Hi, this is Sarah Neller in Rutland. I just wanted to say that I learned a lot today, and that if the email had come out a couple days earlier, I think you would have had a better turnout, and I would come again to something like this. If it was every other month or every month or whatever, I would come and I would learn more and be able to contribute more. So I just wanted to thank you for being here today.
Well, thank you. Claire,
This is Betty. This is Betty in St. Johnsbury, and I do think of this as geographically far more accessible. I have been to Montpelier to a few transformation meetings, but like someone earlier said, there's an agenda, and I wouldn't mind if there was an agenda to start with and other people actually got to comment and then open it up at the end too. But I just feel like I'm totally just watching the Transformation Council meetings. I don't feel included in any way.
Okay. Anybody else? All right, well, if not, we'll definitely schedule one again. I'm not sure of the frequency, but we'll get back to you about it, and we'll get the notice out sooner. Thank you all very much.
Everybody.
Thank you.